Today we're going to master anemia in the simplest way possible, so you can solve any USMLE question without memorizing random facts. Let me ask you something. Why do patients with anemia feel tired? Because their tissues are not getting enough oxygen. In short, why fatigue in anemia? Decreased oxygen delivery to tissues, decreased cellular energy production, leading to fatigue and weakness. Anemia simply means decreased hemoglobin or decreased oxygen carrying capacity of blood. What actually happens is decreased hemoglobin or decreased oxygen carrying capacity. That leads to decreased tissue oxygenation. Red blood cells carry oxygen using hemoglobin and deliver it to tissues. So, the role of RBCs is that 1. Hemoglobin binds oxygen. 2. Transports O2 to tissues. 3. Essential for cellular metabolism. When oxygen delivery drops, the body tries to compensate. That's why patients develop fatigue, pallor, shortness of breath, and tachycardia. So common symptoms are 1. Fatigue and weakness. 2. Pallor, low HB. 3. Shortness of breath. 4. Tachycardia, compensation. Now this is the most important step. Always classify anemia using MCV, the size of red blood cells. MCV classification, key step. Microcytic are less than 80 femtoliters. Normocytic are 80 to 100 femtoliters. Macrocytic are greater than 100 femtoliters. First step in all questions. Now let's talk about each anemia one by one. 1. Microcytic anemia. Microcytic anemia means small red blood cells, usually due to low hemoglobin. In short, microcytic anemia is 1. Small RBCs, low MCV. 2. Down arrow hemoglobin synthesis. 3. Often related to iron problems. You can remember the causes using TICS, that is thalassemia, iron deficiency, chronic disease, and sideroblastic anemia. Causes: TICS, T for thalassemia, I for iron deficiency, C for chronic disease, S for sideroblastic anemia. 1. Iron deficiency anemia. Iron deficiency anemia is the most common type, usually caused by chronic blood loss or poor diet. Iron deficiency anemia is most common worldwide. Causes: chronic blood loss, gastrointestinal I, menstruation, poor dietary intake. The most important lab is low ferritin. You'll also see high TIBC, total iron binding capacity, and low serum iron. Iron deficiency labs. Down arrow ferritin star, best indicator. Up arrow TIBC, total iron binding capacity. Down arrow serum iron. Down arrow transferrin saturation. Classic clinical clues include pica and spoon-shaped nails, called koilonychia. So, clinical clues are 1. Pica, ice, dirt craving. 2. Koilonychia, spoon nails. 3. Fatigue and pallor. 2. Anemia of chronic disease, ACD. In anemia of chronic disease, inflammation increases hepcidin, which traps iron in storage. So, in short, in anemia of chronic disease, there is increased inflammation that leads to increased hepcidin, leading to iron trapped in macrophages, which eventually leads to decreased iron availability. So ferritin is high, but serum iron and TIBC are low. ACD labs. Increased ferritin, stored iron. Down arrow, serum iron. Down arrow, TIBC. Iron is present but unavailable. 3. Thalassemia. In thalassemia, the RBC count is normal or even high, which helps you differentiate it from iron deficiency. Thalassemia. 1. Genetic globin defect. 2. Normal or increased RBC count. 3. Target cells on smear. 4. Sideroblastic anemia. Sideroblastic anemia is due to defective heme synthesis, leading to ring sideroblasts. Sideroblastic anemia. 1. Defective heme synthesis. 2. Iron accumulates in mitochondria. 3. Ring sideroblasts. 2. Normocytic anemia. In normocytic anemia, red blood cells are normal in size but reduced in number. Normocytic anemia. 1. Normal MCV, 80 to 100. 2. Down arrow RBC number. 3. Problem is quantity, not size. The key step here is checking reticulocyte count to see if the problem is production or destruction. Reticulocyte count, key. 1. Low arrow down production. 2. High arrow up destruction. 3. Helps identify mechanism. Low reticulocytes suggest a production problem, such as aplastic anemia or kidney disease. So, low retic, production issue, suggests problems like 1. Aplastic anemia. 2. Kidney disease, decreased EPO. 3. Bone marrow failure. High reticulocytes suggest destruction, like hemolysis or acute blood loss. So, high retic, destruction, suggests problem like 1. Hemolysis. 2. Acute blood loss. 3. Bone marrow compensating. Hemolysis shows increased LDH, lactate dehydrogenase, increased indirect bilirubin, and decreased haptoglobin. So, hemolysis labs shows 1. Up arrow LDH. 2. Up arrow indirect bilirubin. 3. Down arrow haptoglobin. 4. RBC breakdown markers. 3. Macrocytic anemia. Macrocytic anemia involves large red blood cells due to problems with DNA synthesis. In short, macrocytic anemia is 1. Large RBCs, increased mean corpuscular volume, MCV. 2. Impaired DNA synthesis. 3. Megaloblastic changes. The main causes are vitamin B12 deficiency and folate deficiency. So, main causes are 1. Vitamin B12 deficiency. 2. Folate deficiency. 3. Affect DNA replication. Here's the key difference. B12 deficiency causes neurological symptoms, while folate deficiency does not. It is an important exam distinction that you can remember. Both have high homocysteine, but only B12 deficiency has elevated methylmalonic acid. So, lab differences are: both has increased homocysteine, but only methylmalonic acid is increased in B12 deficiency. This helps to confirm diagnosis. Other causes of macrocytic anemia include alcohol use and liver disease. Other causes include 1. Alcohol use. 2. Liver disease. 3. Non-megaloblastic macrocytosis. So, to solve any anemia question, follow this simple flow. Check MCV, classify, look at labs, and understand the mechanism. In short, approach anemia like this. 1. Check MCV. 2. Classify type. 3. Analyze labs. 4. Then finally, identify mechanism. Quick recap. Microcytic means iron problems, normocytic means production versus destruction, and macrocytic means DNA synthesis problems. If you understand this framework, anemia becomes easy. In the next video, we'll go deeper into iron deficiency anemia with clinical cases and USMLE traps.